This segment picks up some bacterial topics that do not always dominate the conversation, but they absolutely matter in clinical practice. Now, these include tetanus, C. difficile, pertussis, bite wounds, and cat scratch disease. So, the thread that connects them is simple. Exposure history matters, vaccination status matters, and when the history sounds unusual, your questions become even more important. Among the gram-positive rods, a few names are especially clinically relevant. Clostridium tetani produces a toxin that affects the nervous system, which is why keeping tetanus vaccination up to date matters so much. C. difficile is part of the normal gut flora landscape, but can overgrow after prolonged antibiotic use because other flora are essentially wiped out while C. difficile persists. That often leads to persistent diarrhea, and listeria is a foodborne concern associated with common or contaminated rather produce, dairy, and other products. So it can grow, listeria, it can grow even under cold conditions, while some other organisms don't tend to do well. So on this slide, think of our recent antibiotic history, our vaccination history, and our food exposure history as some of the really important questions that we're going to ask. Now, just to go back a step, I did say C. difficile. Clostridium is what we're referring to there, Clostridium difficile, and we're understanding that from our perspective, most gastroenteritis, is being viral, self-limited, and the exposure persistent can kind of change the clinical suspicion. Now, if a person has C. difficile and the diarrhea isn't going away, the patient's recently had 3 weeks of antibiotics, the bacteria in the gut is really getting killed off, and this is why the Clostridium is out of balance. So this might be another question that we're asking. Have you recently had an infection, or are you currently on any diseases? With listeria, one thing I didn't mention was, you often hear about this in the news. Lettuce, cheese, and milk products, keep the garden from being contaminated, typically by livestock that would contaminate the soil. Now, the diagnosis often happens here with a blood sample, sometimes a stool culture or other method to detect presence of bacteria. But what I didn't mention was listeria tends to multiply even in cold conditions, so things like ice cream could be areas where we see this develop. So if we consider what you've been eating recently, we're asking about last oral intake, we're asking about use of antibiotics. Did others around you get sick? Did they eat the same thing? Is it just food poisoning or something more serious? As a matter of just kind of clinical relevance, E. coli and Salmonella, they're gram-negative rods in this case. So here we just talked about gram-positive, but E. coli and Salmonella are gram-negative. Whooping cough, pertussis, is, well, it's still important because, vaccine protection is not perfect and immunity can wane over time. And it's especially dangerous in infants because their tiny little airways are smaller and the swelling can become life-threatening. Now, the disease often starts like a regular cold in what we call the Caterhall stage. This is where, it's kind of in the first couple weeks. Now, this is also when patients are generally highly contagious. And then comes the paroxysmal stage with severe coughing spells, and later the convalescent stage where the cough may linger or sometimes recur. So if a college-age patient seems to have a cold that suddenly worsens into repeated coughing fits, pertussis belongs on the list for the differential diagnosis. A practical question that we can ask is whether they're around babies, because that raises the stakes, for transmitting the disease to an infant. Now, pertussis, of course, we said was a concern. The reason we hear it called whooping cough, again, is because of the classic issue with the narrowed airway. And it's actually on the inhale where we get that whooping classic type of noise as they're trying to catch their breath. They're trying to get it in as best they can. Now remember, there is a vaccine for this. It's the Tdap vaccine, tetanus, diphtheria, and pertussis. Pertussis in that cohort is the least effective component. And another issue with this vaccine is that because it's a weak vaccine to begin with, immunity often falls off as people get older and the vaccine becomes less effective. It can also be that patients may have allergy to the pertussis element of the Tdap. So they get an initial Tdap and then they end up with some type of hives or other reaction. Then this has to be eliminated from the future course of administration. All of these considerations, coming into play, talking about our medical history, help to identify whether or not maybe pertussis should remain on the list for the differential diagnosis. Let's turn our attention to bite wounds. They deserve our respect because they inoculate bacteria directly into the skin. Classic human bite, we see that on the bottom figure there. Human bites are often linked to fights or classic scenario on the athletic field where it's unintentional, but a hand strikes another person's tooth, maybe as they were changing or turning direction and had incidental contact. Now, animal bites bring a broad range of organisms as well. Superficial here, maybe we can wash them thoroughly, keep them clean and monitored, but if we see increasing swelling, drainage, or more than minimal discomfort, especially lymphangitic streaking, where that is moving up an extremity, that's not something to ignore. Now, those are referral findings that in sport medicine and first-line care, your initial management might be pretty simple, but your threshold for referral should be low when it comes to an identification of spread, and that's become evident in the as we see in the picture with the lymphangitic streaking. Of course, that is indicative of inflammation of the lymph channel. And here in the photo with lymphangitic streaking, this is a case where we are observing an ascending infection, and this should get referred and checked out immediately. Bartonella hynsale, cat scratch fever or cat scratch disease, usually comes from exposure to a cat scratch or a bite, and it's associated with the Bartonella hynsale bacteria. Now, this could come from the saliva and flea-related ecology of cats, but could also come from fleas, body lice, sandflies, or contact with flea-infested animals. Now, there's not evidence that I'm aware of that ticks spread Bartonella infection in humans. So in the United States, probably the more common way that we're getting this is in fact from cats. But a common question might be, how is it identified? Well, it's through serology or the inspection of the blood for antibodies. And once identified whether it's there, the physician may be looking to identify, is it immunoglobulin M, the IgM, or is it IgG? And these antibodies are going to tell us about whether or not the infection is a first time or repeated occurrence. Now, there's a rapid test for detection of the anti-rabies virus as well. So these can also be done, as we're looking at the antibodies in the blood. So a common question that might come up is, should I have a Bartonella test repeated to determine if the infection is gone? In other words, it's been months since I was initially diagnosed. And the answer is actually no. Most Bartonella tests look for the antibodies, and your body actually is going to continue to produce them for months or even years after the infection is gone. So it's not uncommon to say the antibodies would still be elevated months or years after the initial infection. So a repeat test to determine whether it's still there, there's not really a lot of utility to that. Now, complications, I mentioned, those are not the norm, but important to keep in mind that if those persist or those develop, getting into the physician's office to get further tested or treated is certainly of significance. Again, the importance also here is to connect the history to the exam. Of course, was there cat exposure? Were we scratched? Were we bitten? What's the location? What symptoms are we presenting at? All of these common symptoms kind of tied together with the event leading up to the incident per se is going to help to identify whether or not this is present. And then a blood test is going to be the more definitive mechanism. So this slide's a great reminder to connect the history to the exam. So if you see scratches and we're looking at these regional lymphadenopathy, a patient who has a cat that climbs all over them, I think the obvious question, could it be Bartonella? And that kind of pattern recognition helps you to move from a vague complaint to a more meaningful differential diagnosis. So the takeaway here is that less common does not mean less important, but vaccination history, recent antibiotics, food exposure, animal contact, bite mechanism, they all change how you interpret a patient's symptoms. So if we are asking the right questions, if we're determining the right medical history, we might be able to better quickly identify whether a case is going to be of importance for immediate referral or is it something that is going to need further diagnosis down the road.